Thank you very much. Welcome.
Thank you very much. It's very good to see you all, even it's virtually. I have many friends that I can see you. And thank you, Chiat, for the opportunity to present my topic of increased NT and the early fetal brain. And we know that this will be the topic that we'll discuss. And the main question is, when we find increased NT, is it that we send the patient to karyotype, or we send the patient to early anomaly scan, to scan or to karyotype? And we know that currently the first option given to patients with increased NT is fetal karyotyping, followed by anatomy scan in cases with euploid fetuses. Even when we have done this survey in GMED, still 59% sent the patient first to CVS and then to anomaly scan, and my goal is to change this paradigm. We know that the prevalence of chromosomal defects increases exponentially with NT thickness from about 20% to NT of 4 millimeter to 65% for NT of 6.5 millimeter and more. In the chromosomally abnormal group, there were 50% as trisomy 21, 25% trisomy 18 or 13, 10% at Turner syndrome, and 5 triploidy. We can talk about karyotyping without, it's not suffice to measure the karyotype, but we have to consider today the CNV, the CMA, and we know that 8.3% of CNV were considered to be pathogenic and clinically significant, and the incidence rose with sonographic anomalies seen at the anomaly scan. Land found that CMA were pathological CNV were found in 12.8% of cases, and Maya found that the pathological CNV were found in 1.7% with NT of less than 2.9 millimeter, and in 13% with NT of over 3.5 millimeter. So in most of the cardinal chromosomal syndromes, like trisomy 21, trisomy 18, 13, Turner and triploidy, as well as pathogenic CNV, there is a severe structural anomaly. What about increased NT and normal karyotype? We know that the prevalence of major fetal abnormalities in chromosomally normal fetuses increases with NT thickness from 1.6% with normal NT to about 65% for NT of 6.5 millimeter and more. In the total incidence of unfavorable outcome in this group was 32%, in contrast to 7.5% with normal NT. And in the fetuses with enlarged NT and normal karyotype, 11% as structural anomaly, 4% were affected by genetic syndromes, and additional 8.5% were affected by single gene disorder. The group of Soroka and Nicolaides found that the prevalence of major anomalies is substantially higher than expected in the general population. So in up to 45% of abnormal NT and normal chromosome, there is severe structural anomaly, and there is up to 32% of unfavorable outcome with increased NT and normal chromosomes. What about congenital heart defects and increased NT? We know that the ability to perform a full cardiac examination increases from 20% at 12 weeks to 92% at 13 to 14 weeks. And Bellotti found the CHD were detected in 16.5% of the fetuses with abnormal NT. The Ascendo found that heart defects were the most common defects in fetuses with trisomy 18. And John Hyatt found that when the NT is 3 millimeter, the incidence of CHD is 4.4 per 1,000 cases. It rises to 233 per 1,000 cases when the NT is 5.5 millimeter and more. So, to summarize the cardiac defects, overall up to 80% with normal karyotype, 5 to 7%, and with abnormal karyotype up to 80%. Are we capable of providing anomaly scan such early in pregnancy? The group of Lindsay Allen detected that diagnosis of heart malformation can be made reliably even in the first trimester at the time of nuchal translucency measurement. Wagner found that the detailed anomaly scan at 11 to 13 weeks gestation can identify about 95% of fetuses with trisomy 18, 13, triploidy, and Turner. And Singelaki from the group of Nicolaides found that 43% of the fetuses with non-chromosomal abnormalities were detected at the 11 to 13 weeks of gestation. And the group of Katia Bilardo concluded that an early scan done at 12 to 13 weeks performed by competent sonographers can detect about half of the prenatality detectable structural anomaly and 100% of those expected to be detected. So in over 30% of abnormal and normal chromosomes and abnormal NT and non-abnormal chromosome, there is severe structural anomaly which can be detected at the 11 to 14 weeks scan. And Suoko and Nicolaides concluded that the vast majority of fetal abnormalities associated with increased NT can be diagnosed by a series of investigations that can be completed by 14 weeks of gestation. Benoit, in his course in Monaco, stated that complete examination of fetal anatomy is feasible at 12 to 14 weeks. If the fetal structural anomaly is already present at 12 weeks, and it is possible to see the major fetal malformations during the first trimester scan. Bornstein, more than a decade ago had evaluated the utility of detailed first trimester anomaly scan upon detection of abnormal fetal nuchal translucency, and he has found 27% with severe structural anomalies, and after CVS, another abnormal 33%. And we have added our share to the literature by this study, the added value of detailed anomaly scan in fetuses with increased nuchal translucency. We had 43 patients with the mean age 34 years, with mean gestational age of the scan at 12.4 weeks, with mean nuchal translucency of 4.5 millimeter. And we have found major anomaly in 70%, minor anomaly at 11%, one of them had Down syndrome, but the most important thing that when the early scan was normal, all cases had normal vaginal delivery. And let's move to brain or NTD cases with increased NT. And we start with anencephalus or acrania at 10 plus 5 weeks of gestation. This is case of acrania or anencephalus at 14 weeks, which was missed at the nuchal translucency scan. This is a case of encephalocele at 11 weeks of gestation, and this is at 15 weeks because she didn't terminate the pregnancy then. This is a case of spina bifida, meningomyelocele, as you can see the early banana and lemon sign, or as Fred Ushakov has evaluated the crash sign. Spina bifida and meningomyelocele, another case in early pregnancy. And this is a case by the great Ritzoko Pu, a very early case of at 9 weeks with meningomyelocele. body stock anomaly can cause severe disruption of the skull and brain, as you can see in this case, and this is another case at 12 weeks of gestation, where you can see the short cord, the disruption of the head and brain, and here you can see the rendered view of this anomaly. What is this triad of polydactyly, encephalocele, and enlarged polycystic kidney? This is a case by Dr. Swaz, and this is our case with increased NT, omphalocele, abnormal absence of the nasal bone, heart defect, enlarged kidneys, and polydactyly. And indeed, this is a case of Meckel-Gruber syndrome, a rare autosomal recessive genetic syndrome, and the typical triad encephalocele, enlarged polycystic kidney, and post-axial polydactyly. The pathophysiology is failure of the mesoderm induction, and today we call MGS as part of the ciliopathies. Of course, chromosomal abnormalities share the fetal brain, as you can see in different chromosomal abnormalities here. This is a case of trisomy 18 at 12 weeks of gestation with a combination of septated cystic hygroma, omphalocele, AV canal, and abnormal posterior fossa, and it was terminated, and the karyotype was trisomy 18. This is our study about triploidy at 12 to 16 weeks of gestation, and you can see very well here the abnormal disproportion between the head and the abdomen, and the abnormal posterior fossa in these cases of early triploidy. This is a case of Robertsonian translocation with early posterior fossa and cerebellar abnormality, in addition to heart defect, polydactyly, and abnormal face. And I'll finish this examples with 3 recent cases. All were found with increased NT, all were sent for CVS, and before CVS they came for anomaly scan, following which they all had terminated the pregnancy with trisomy 13. The first one, age 39, 2 healthy kids at home. Gestational week was 11 plus 4 weeks. And the ultrasound finding were the fetus appropriate for 10 plus weeks. The NT was 3.8 millimeter, holoprosencephaly and proboscis. As you can see here, the holoprosencephaly with the proboscis, remember 11 plus 4 weeks of gestation. You can see here the rendering of the proboscis.
Yeah, Yaron, time is up. How many slides?
No, I started a bit earlier. Give me 1 minute or 2. The next one is 42 weeks, 42 years, four healthy kids at home. We'll see the sonographic findings, increased NT, early IUGR, holoprosencephaly, and the last case with limb abnormalities, as you can see here. And the last case is...
That's it, fine, thank you.
I haven't finished yet, 1 moment, please. The last case is holoprosencephaly with arynia, with AV canal, and we have to remember the disadvantage of early scanning. I'll run through it. Not all of them are detected in there. We have found that the presence of major malformations is an independent variant for the existence of malneoploidy with odds ratio of 8.1, and we suggest to scan before karyotyping. And the take-home message is increased NT is associated with chromosomal as well as structural heart and brain abnormalities. Most anomalies can be detected as early as 12 to 14 weeks of gestation. Remember the developmental anomalies, late brain findings, and we suggest to scan before karyotyping in case of increased NT. And I thank you all for listening.
All right, can you stop your sharing, screen sharing? Thank you very much.
Yes.
All right, Olu Shapi, it's your time now for the discussion for 10 minutes.
Okay, maybe we can proceed with the questions for Zalel, Professor Zalel. Some questions from the audience. From London, Avidya Nejat asks, if NT is above 3 and normal structure, do you still do CVS or amnio?
Yes, I do. I do, because we know that even normal scan doesn't exclude chromosomal abnormalities. And NT 3 millimeter is not normal, but when the structure, when we don't find any structural abnormalities, there is a greater chance that the amnio will be normal as well.
Okay. No more questions for Zalel, but maybe I may ask a question for you. For the differential diagnosis of triploidy, the types, the andric and the digynic type, do you comment on the differentiation, the ultrasound findings for differentiation of these types of triploidy?
Yes, but our study was evaluated the digynic triploidy and not the other one.
Good.
Okay.
Cecilia has a question or comment on. Please welcome, unmute your, yes.
Yes. No, actually, my comment was about the CVS or amnio. We will not do it if it's over 3. We will do it if it's over the 99th centile for the crown round length. And we will also do array CGH.
Yeah, that's a good comment. Sorry about my pronunciation in Spanish. How do you pronounce your first name? Cecilia, Cecilia?
Cecilia is okay.
Cecilia is, yeah, sounds good. Very good. Welcome.
Thank you.
Question or any comment from the speakers or panelists?
Just one comment.
Yes.
If I was misunderstood, we don't do karyotyping anymore. We do only CMA. The time of only karyotyping is over. If I was misunderstood.
We got your message. Thank you. There is another question for Ansem Kuryak, who, you know, the one participant.
Very short question and comment.
He's asking about, is there any fetal seizure condition in utero? Fetus, whether or not fetus is having a seizure.
Is this question or?
Question.
To me. Please repeat it.
Yeah. Is fetus having any seizure in utero?
Any seizure?
Seizures.
Seizure.
Yeah.
Even the fetus.
It does, of course. But if you follow up high-risk patients with abnormal kinetest, you will see all sorts of seizures. My question to Yaron, you are very good in antenatal detection, but this is conference on brain. You know, how much by your information, genetics is causing brain development, whether structural or cognitive? Is there any connection between cerebral palsy and abnormal genetics?
You know, it's hard to say today. Pardon?
I'm asking every one of you, panelists, do you know any information, personal or from huge statistics, that genetics is causing cerebral palsy? Most frequent chronic motoric disability, more than 1 million patients with cerebral palsy in adult and young age are every day at the airports in America, the largest number. Big public health problems. The incidence didn't change since 1952. This is a good reason to understand that cerebral palsy is a static problem. We see the patient and we did nothing, absolutely nothing. We increased incidence of cesarean section, fetal monitoring, fetal blood sampling, magnetic resonance, ultrasounds, also nothing reduced incidence of cerebral palsy. Now, the question to you is purposefully done because you are deeply in the field of genetics. You show trisomy, you show many elegantly detected cases. And of course, you go in literature. Is there any data?
Yeah.
How genetic?
Yaron, do you have an answer at the moment?
I don't have answer regarding the connection between cerebral palsy and genetics, but I think it's a matter of time. Everything is connected today to genetics.
Yes, you're right. Nobody has any answer at the moment. Yaron, there is another question. Dr. Nejat is asking about, yes, you do CMA, not why? Because maybe you will be missing, some balanced translocation without karyotyping. Do you care?
In very, very rare cases, it's a matter of balancing. If you pay also for karyotyping, our Ministry of Health has decided and allowed the patient to do only CMA because of the rarity of the cases when there is a normal CMA and abnormal karyotyping. I know about the abnormal rearrangement and the translocation, but this is our policy of the Ministry of Health.